If you're, so let's say 40 years old, maybe you're not going to get atrial fibrillation until you're 65. If you're lucky, maybe it's 85. If you're wearing a watch the whole time, it's going to pick it up when it arises. Otherwise, what you're talking about doing, maybe go to the doctor once every few years. If they think you're at risk, you might stick one of these patches on.
I'm going to open this episode by telling you something that was frustrating this morning, and that was that I had to take my car in for like the 50th time, and I'm getting very anxious when I'm opening up the estimate, and it says something has kind of blown, like a gasket in this canister, and I'm thinking to myself, surely there was some lead time in the other 49 times that I came here where there was some kind of structural abnormality or some kind of retrograde reflux, something to clue in that this is going to be a problem that wouldn't end up being four figures. That concept, and if you've appreciated that, whether it's through HVACs or anything else, is, I'm sure, a point of frustration for people that have to do with specialized organs, especially ones that are closed system, especially something as vital and important as the heart and cardiology. And to that note, and really the concept of what's called wearables, of that kind of clue in of something that's about to go bad well before it does, is the hope and the thing that we get very excited about when it comes to wearables and the AI processing and all the stuff needed to kind of give us good insights and a heads up. That's what we're talking about today with Dr. Euan Ashley, who is just an absolute force when it comes to not only being a cardiologist and being at Stanford, but also his kind of understanding of different worlds that all come together and should. Genomics, fitness and cardiovascular health, and also this concept of preventative or prospective kind of insights to be able to not have a reactive world that we live in. So with all that said, I'm extremely humbled to have you here, Euan.
Yeah, thanks so much for having me. I'm really excited for our conversation today.
Yes. So please tell me, however you'd like to start, because I've seen you've dabbled in several different things. Awesome Wikipedia page, which is, it was a dream when I was younger. But you talk about fitness, you talk about preventative stuff. You've done that a very long time because this organ, that is the heart, is sometimes like a rubber band. It can overstretch and you can't get that re-stretchiness of a rubber band that you want sometimes. It's got complex parts and machinery. I can tell that you've always had a focus on, let's just keep bad stuff from happening the best we can. What is it in that world that then brings in this concept of how we can leverage tools and wearables and AI to hopefully make that even a better world for what you've been doing a long time? What is it that you've recognized that maybe is a point of frustration or something that needs to be fixed?
Yeah, well, I think your story there at the top is a perfect example of two worlds that we live in. We live in one world where we're driving around, we're going on bridges. I have a little pamphlet that tells me about the bridge inspections that are done in California bridges. Because we know over time that's going to wear, and that we should check certain areas because there'll be certain vulnerable areas, and at some point that bridge will fail. And we shouldn't wait till the bridge fails because that's a bad idea. That's the world we live in normally. That's the world mechanical engineers live in. But somehow when we move over to thinking about the body, instead of thinking about your car or thinking about bridges, we are just kind of accepting that we're just going to wait till something goes wrong and then we're going to react to it. And I know why we do that. We have trained generations of medical students and young doctors to say, well, we shouldn't overtest because what about the false positive rate? But the reality is that that's a statistical problem. And as long as you understand the statistics of the test that you're doing, you can overcome that, or you can at least understand it well enough. And the reality is that alone is not a reason to wait to something, wait till the wheel drops off before you actually go and look at what might be brewing and what might be coming. And so I think one of the problems with our reactive medicine is I think, very nicely encapsulated by your story. There's lots of examples of it, and even we're beginning to make a little bit of progress. I mean, and one of the most common we talk about is atrial fibrillation, that rhythm from the top of the heart where the top chambers that normally fill the bottom ventricles, instead of beating in time, start to just wobble instead. And the issue is not that they're wobbling or even that your heart goes somewhat erratically and fast, but rather that small blood clots can arise in the center of your heart, as you know well, and they can travel to the brain and cause a stroke, which is devastating. And very large amount of healthcare expense and a huge amount of emotional burden that comes from people having strokes. One of the most common causes of that is atrial fibrillation. We now have a method of picking that up. a watch, one that's, I happen to have an Apple Watch, but multiple watches now are able to do that in advance. And so we have this tantalizing possibility of picking up the major risk factor for stroke when it first arises. We don't wait till it's happened 10, 20, 30, 40 times and eventually a small clot breaks free and goes to the brain. Rather, we're monitoring people over decades, comparing themselves to everyone else we know about, but also comparing themselves to themselves from a few years ago. And we can talk more about that. But I think one of the challenges then is that we're so reactive. We need and have this opportunity now to be more proactive. And so when I think about what is the problem to be solved, I think that's one of them. We need to move to a world where instead of waiting for the worst to happen, we get ahead of it and start thinking much more carefully about testing and understanding who's at risk and getting ahead with good treatments.
Yeah, and where else? I mean, would then atrial fibrillation and stroke, which we're all very familiar with, stroke is mostly reactive, and it's not even death and survival that we're talking about. We're also talking about true debility. I mean, just being in a locked capacity. I remember thinking that in residency one year. I'm like, when you had this what's called aphasia and you're unable to say the word you want to say, and the fluster and frustration and angst of a patient I saw, I was like, I can't say I get it, but I can only imagine how challenging that is, let alone with moving, an entire half of your body, et cetera. And to your point, these are things we've all heard of. And it's like there's a significant subset that it doesn't have to be, quote unquote, have to be this way, right? Like, one example I think about is always when my patient comes in and says on a CT head or MRI, it's like, and what does this mean? Mini strokes or mini this and that? I'm like, it says I've had strokes. Have I had strokes? I'm like, well, technically they're called infarctions. But it's this whole thing of like, oh, by the way, rather than like, and they've had now many over years of the same concept of how do we not have so much of this? Because, this obviously has a downstream effect later.
Yeah, no, I think that's exactly right. And people understand that this is a really debilitating illness, and, the rehabilitation costs when we think about trying to bring people back to their former functioning, I don't, that there isn't another condition with greater rehab costs in our healthcare system than stroke. And so when we think about the possibility of preventing that and giving people agency so that they can make decisions earlier in life to help reduce their risk of having a stroke, that I think is part of when we think about the future of medicine, something that is really exciting, that we might be able to use technology to get ahead of some of these challenges.
Now, I love that. And another thing I love is something that I had to go to my son's second year class. And my wife and I, my wife and I are both oncologists, but we have to share a bunch of random facts. And one of mine that I like to share, and hopefully it's right, so you can tell me if it is or not. But I'm like, did you know your heart cell is the one cell that you can take out and it'll have its own its own beating without necessarily being told, right? We have volition where we kind of like move our arms or move our eyes, etc. But it just beats on its own, like outside of your body. And it's because it has this autonomous or basically inherent capacity to beat at a certain level, which a lot of people say is an adaptive evolutionary thing to say, like, you need blood and oxygen for the, vitality of all your tissues. But the problem is you have a bunch of those independent beaters. And for the most part, if I understand correctly, is they all listen to the thing that's faster and kind of rate variability, which is, we hear a lot about when it comes to survival, et cetera, long-term health. But it can get, I would say, like, annoyed, if not pissed off, right? And then now all of a sudden it's just causing calamity. And it's like when one kid is being bad and I'm too hard on my older son, I'm like, Ashwin, when you're bad, the other kids are bad. It's like all of a sudden you just have this like crazy rate where it's just superseding the chief or the parent. And I guess, that I explain it that way because there's different reasons that it can get mad. I mean, one is if somebody was drowning, I'm sure that causes an oxidative stress. That's what's called acute. But by far, I would imagine most of these are chronic processes, whether it's impaired oxygen delivery to where it's super hungry or hangry, as somebody would say, or it could be a stretching where it's like, you've just spread me too thin. And these, happen over time with valvular stuff that's not closing off, clamping off the way it should. So many different reasons. Is this the kind of thinking that went behind, if I understand it, are these telling you before you have AFib or telling you before you have a stroke from AFib? And how did this all come together?
Yeah, no, I mean, your story also again really resonates with me because I mean, one of the main reasons I became a cardiologist was because I became fixated on the heart during one of our early physiology labs. I come from Scotland. I trained at the University of Glasgow, and as you know, in medical school, in those first couple of years, you're often doing very basic, learning fundamental things about the organs. One of the labs we would do is we would go in and sit in these old rickety wooden chairs, and behind the scenes they would extract a heart from an animal. I think it was a rabbit, but it's a bit fuzzy now in the past. And then this beating heart would come out in a little dish, and then you had to basically hang it by a cannula, and it would beat spontaneously for hours. And your job then for the next 4 hours was to keep it alive. And you could give it adrenaline, it would go faster, or you could give it a beta blocker, it would go slower. You had to feed it sort of oxygen and make sure it had fuel. And this was I watched this thing for those hours just beat this sort of beautiful symphony of movement, this electrical activation that you described where everything is being driven by those pacemaker cells. And then the twisting of the heart as each individual chamber is working together in harmony with those valves in between. I mean, it was just exquisite. And I stared at that. I thought, I am going to dedicate my life to learning everything about that organ.
I love that.
And so I'm reminded of that just with your story when you're talking about the pacemaking cells. And so then to connect back to atrial fibrillation, yes, normally those pacemaking cells are at the top of one of the atria, and they pass that electrical activity down through the rest of the heart, and it's called an electrical syncytium. So the electrical activity spreads through, and normally that happens the way our heart beats, ba-dum, ba-dum, ba-dum. The heart beats like that. But with atrial fibrillation, those top chambers, instead of those pacemaker cells giving a straight pacemaking beat, low if you're resting and higher if you're exercising, now there's just chaotic, irregular, random electrical activity being passed down to the bottom chambers. And so instead of that very regular beating, you have this chaotic random beating that is truly, in fact, you'll remember we call it irregularly irregular. As only physicians could come up with that.
It's like bad. It's badness.
Exactly. And so and then while that beating from the lower chambers is usually pretty intact, unless your heart goes very fast for a long time, it's the upper chambers that are really just kind of wobbling now, where the blood is not moving fast enough, and then it starts to create a clot, and then that clot can get passed through your circulation and go to the brain. So that's the basic system that has gone awry with atrial fibrillation. And one of the reasons that you could pick it up with a wearable is because in normal circumstances, your heart is very regular. So if you look at the scatter between individual beats and the time between each individual beat, it's usually quite small. I mean, if you're younger, especially, your heart rate goes up and down as you breathe. But for most people, it doesn't go up by very much. And it remains very regular. But if you're in atrial fibrillation, the distance between each beat is essentially different. It's somewhat random. And so the variation between beats gets very large. And that's actually what most of the watches pick up. So I think we'll go on to talk more, I'm sure, about very sophisticated artificial intelligence approaches that we're using in various ways in medicine. But one of the interesting things is to pick up atrial fibrillation, you don't need any of those. You basically have a detector for regular versus irregular. And over time, of course, because you're actually wearing the watch, plus some people wear it most of 24 hours, then that watch is able to pick up this irregular beating if you have it over the course of a few minutes or longer. So it's a very powerful technology to pick up something that otherwise would require you to go to a doctor and stick leads on your chest, and maybe you'd wear that for 24 hours or 48 hours, or with the near patch ones, a couple of weeks. But you think about that, if you're so let's say 40 years old, maybe you're not going to get atrial fibrillation until you're 65. If you're lucky, maybe it's 85. If you're wearing a watch the whole time, it's going to pick it up when it arises. Otherwise, what you're talking about doing, maybe go to the doctor once every few years. If they think you're at risk, you might stick one of these patches on. So the new technology provides that. And just to pick up on one other thing you said, which is really important, the risk factors for atrial fibrillation turned out to be very similar, and this is not something we realized till more recently, very similar to the ones for heart attack. So when you think about the things that make you at risk of a heart attack, we think about things like physical inactivity, being sedentary, or diabetes, or high blood pressure, or smoking. Those are the family history, very important. If we think about those things that predispose us to having a heart attack, we've often thought of the heart attack in one box and then rhythms like atrial fibrillation in another. But it turns out that since all of those are lifestyle factors, the sort of general inflammation that occurs in your body that predisposes to coronary artery disease, which can then cause the heart attack, actually that inflammation also predisposes to atrial fibrillation. So the sorts of risk factors we talk about and the sorts of ways you can alleviate them, let's get up out of your chair and start moving around and start exercising. Let's talk about your diet and let's think about getting your cholesterol down and let's definitely stop smoking. All of those things also reduce your risk of atrial fibrillation and stroke. And so there's a lot we can do if we understand that you're at risk.
100%. So, and I want to talk about that more because I'm, as you say that, I'm wondering, is it because the blood supply, which is keeping the cells from getting hangry, if that's compromised at the pipeline, then maybe they're getting more hangry. But before that, I know people are listening and they're maybe freaking out because they're saying, I have skipped heartbeats. It's probably one of the most frequent messages I get on social media for whatever reason, because most of my content's oncology. But like, I'm sure I'm having a heart attack, my heart skips a beat, this and that. There's something called PACs, which are premature atrial contractions. Mm-hmm. It's just a little like, let's say like a default at the race, but not because they can't run it and they're out. They just defaulted so that you get another chance. If you could maybe explain those just for 2 seconds to alleviate others, because I just tell people, not on social media, but my patients, I'm like, these are very PACs. But number two is AFib is never as kind, much like the human body is when it can be enigmatic, of just giving you AFib or not binary. The reason you said 24 hours of a wearable is because you can have this annoying thing called intermittent AFib, to where it's actually all behaving and then it's not at certain points and then it is again. And so it's not always a sustained, easy shot EKG, 6-12 seconds I can automatically appreciate. But we are not talking PACs. Or is your intelligence telling us that maybe that is relevant in any way? Because I hope not.
No, it's a good point. Yeah. So first of all, to clarify, there are lots of ways your heart can go out of rhythm. And atrial fibrillation stands in sort of the middle. There are much more dangerous rhythms than atrial fibrillation, ones that cause instant cardiac arrest, where somebody would collapse and be on the ground unconscious. But there are also much more benign rhythms than atrial fibrillation that we think of as things that really aren't in and of themselves going to cause any harm at all. And those are what most people are feeling when they feel skipped beats. And they can come from the top of the heart, as you described, those atrial premature contractions, and you can feel it as a skipped beat. Or they can come from the bottom of the heart, like a ventricular premature contraction. And sometimes people are more likely to feel that, like the bottom, the big pumping chamber beats just a little early. And actually what you tend to feel is not so much that first beat that comes early, but rather the next one. Because what happens is there's then a little delay and the heart fills more and more and more, and the heart responds with a stronger next beat. So most people feel the next beat, the one after the skip one, if you like, because it's stronger than normal. And they're like, oh, what did I feel there? So they can, and some people feel every single one of those they have. And some people will come into our clinic and say, I had 3 yesterday, I had 2 today, and they literally feel every one. And then we have other people who come in who have tens of thousands and don't feel any of them. So it's very variable. I mean, the diversity of humans and humanity is just incredible and wondrous to see. Now, the amazing thing is, for most of those beats, even the people who are having thousands, they aren't of any significance and they aren't anything to worry about. Of course, the more you have, the more we're likely to want to investigate a little bit and to make sure that that isn't a symptom of something else going on. But a few extra beats here and there, everybody has those, and that's something that is completely normal. In fact, if you've just had a cup of coffee, you're a bit more likely to have them. And some people do feel their heart a little bit more jumpy after that. If you have any concerns, of course, you should talk to your doctor about it. But in most cases, it's important for your listeners to realize that in most cases, skip beats are going to be benign and aren't going to indicate anything other than you have 3 billion beats in your lifetime. Some of them are going to come a little early and some of them are going to come a little late. And so that's certainly an important clarification.
So let's talk about how you get excited about AI, but not just AI, but really the plethora of data. Usually when I talk about it in a cancer context, I say the plethora of aggregate tragedy because like there's just bad outcome, like, and toxicities. And we need to, I'd say pay homage to be able to really process and learn from this aggregate to be able to reduce that aggregate over time. Similarly, how are you getting excited about the potential reality that we are less reactive, less in economic toxicity, and able to, I guess, two-part. One, take everything that we have and know and learn from it, but then at a more granular personal aspect, take technology and clue us in based on the aforementioned, which is, to get these patterns. I'm sure that there is some, like the example I use, I'm like, where we had a wearable, there was data on a wearable that was able to kind of clue us in on early pneumonitis or disease from the flu and other viral things because of just the panting that was required or the heart rate increase from the same flight of stairs you do all the time. I mean, that's why Google Maps is so good about telling you how long it's going to take get there, depending on the time of day. It's not because it has a magic ball, but because it has a ton of data at this time in this area, in the past. So, and then, I read that sleep cycles are actually something to hack because the difference, like different stages of REM actually clue you into having more significant variations of where you are supposed to dip low and dip high. So where do you, that's too many questions, I'm sorry, and I have a habit of doing that. Where do you get excited? What are you looking into? And tell us about it.
Yeah. So let me pick up on a couple of those things. First of all, what you hit again one of my favorite topics, which is the power you gain from comparing you with you, you today with you 5 years ago, you 10 years ago, and we've always scratched the surface of what we can do with that data, understanding trajectories, life trajectories. There's actually a very nice study on this quite recently where they looked at lab values, and instead of saying comparing you to like 10,000 other people, and you're lucky if it's 10,000, but some other panel of people, and deciding that there's a normal curve distribution of people's numbers, like could be sodium or potassium or whatever. It's usually not matched to ethnicity or age or anything else. It's just a standard panel. And then you get your number and they say, well, here's where you fall among this group of people. Now that's useful data. And I'm not saying we shouldn't have that. But just as powerful, if not more powerful, is for you to know, for you, what was your number a year ago, 5 years ago, 10 years ago, 20 years ago? Because over time, we all are getting older. We're all much more likely to get all the degenerative diseases as we get older. And we know that the statistical power you get from comparing repeated measures on the same person is just greater. Because you might be that you normally live at the bottom 10% for this particular number. It might be sodium, it might be your creatinine, your kidney function. If you know that, then if you drop just a little bit, you know that you've changed very little. But you might have just dropped out of that confidence interval that most of the panel of normal people are in. And so suddenly you'll get this big alarm bell. But then reality is you haven't changed very much from where you were. And so that's just one illustration of the power of kind of life trajectories. And I think Wearables is one technology that would allow us to take advantage of that. But going more broadly, I think, beyond that to the excitement, I think, around what artificial intelligence can bring, there's two major areas that I'm particularly excited about the impact that the new AI can bring. I say new AI because remember, I mean, the term artificial intelligence was coined in the 50s. There was like a golden period in the 50s and 60s for artificial intelligence. A lot of work done here at Stanford, a lot of work at MIT and Cambridge in the UK. In the 50s and 60s. And then there was this kind of AI winter, they call it, in the 70s, 80s, and maybe 90s, depending on where you count, where very little happened in AI. And then as we got into the 2000s, it picked up speed again. Some major leaps forward in technology took us to the 2010s, which we call the deep learning era, which is where we were able to suddenly say, oh, well, that's a dog in a photo, or, this is a Frisbee, or that's a beach. And very important deep learning contributions were made there by Jeff Hinton and Jan LeCun and others. But that took us to the moment we're in now, which is only a couple of years old, where we're in this large language model moment, which most people think of as synonymous with ChatGPT. But of course, now we're hearing so many other things, DeepSeek and Gemini and Claude and lots of others. It's having a huge impact on our entire world. And it's something that is on our lips because it's on the front page of our newspapers. It's not something that's happening off in that one corner of the tech world. It's literally impacting all of us, and we all have access to these models. What can they do in medicine? That's something that we think about a lot at Stanford and in the Department of Medicine here. And there's two areas that I think it's really transformative. One is already here, and one is about to be here. And the first is that The burden of paperwork has been increasing for decades in medicine, and you know this really well. Every time we see a patient, we have to write notes. That's always been the case. But of course, now in a world of cut and paste and a world of being able to bring in other data, the burden of paperwork just seems to have gone up and up. And what many of your listeners will be familiar with going to see a doctor, and instead of making eye contact with the doctor's busy, turned to the right or to the left, clattering away on their keyboard, trying to do their best to connect with you, but in reality writing the note at the same time because they have 15 other patients and they're going to have to keep moving in the day. We're all familiar with that. And that is suboptimal. That is not a good situation. And as doctors, it's not fun either, because we went into this life and this world and this profession that we dedicated ourselves to because we love people and we want to help people. And so to have patients come in and then for you to have to stare at a screen is very frustrating. And then that overhead of that burden of paperwork is with us and leads to burnout. And we know that burnout is a very real phenomenon for our doctors and healthcare workers. So how can AI help? Well, a real thing that is here today, and we're lucky enough to be able to use it in our clinic, and it's rolling out in many other centers across the world, but will shortly be available for basically anyone who wants it, is a thing called an ambient scribe. Some of us are used to the idea of a scribe, an actual human sitting in the corner of the consultation room, taking notes and then typing up the notes and then just making the whole thing simpler and allowing the doctor and the patient to make eye contact and to really connect on a human level. Well, not surprisingly, it turns out that AI is actually really good at that. It's really good at listening. It's really good at understanding or being able to map what it's hearing in audio to actual words. And then the language models can now parse those words and put them into sentences. And so ambient scribe technology is here today, and I can tell you it is transformative. We've been using it in our clinic for the last few months. Transformative for one, because it reduces the burden of paperwork. So you come out of the room and there's already a beautiful note written and it's pretty accurate most of the time. You do some light editing and you move on. But much more transformative is in the room with the patient, because you're sitting there and it's just listening and you are making eye contact, making a human connection with the patient, really hearing their story about how life is for them. And not having to worry about clattering away on your keyboard or dropping the bill or whatever else you had to do. So for me, that's maybe the single most exciting advance that AI has brought to my world in biomedicine. And so, I just think that's a great example of where technology allows humans to connect better. We always worry about the technology getting in the way of the human connection. Here's a great example of the reverse. It kind of gets out of the way. And the second example, and then, we can talk some more, is something that we're calling the democratization of specialty care, which sounds, a whole bunch of syllables. But actually, put this way, is that there is an opportunity through these models to be able to if most people can't get themselves to a highly specialized doctor, if they have a rare disease or even if they have a common disease but need a specialist, they're maybe able to get an appointment with their local family practitioner, their GP. But they aren't able to access care at Stanford and care at Harvard if they want to, or any of these big name sort of places. I think language models allow us to take that super specialty and put it in the hands both of their general practitioner, first of all, but also directly in their hands. I mean, there's plenty of reasons for caution around medical information and language models, but truly this is the future, and I'm already convinced that there are easily ways to do this safely. We can empower the general practitioner who's local. This could be anywhere in the world, or empower the patient themselves to interact with this, what we might call chatbot, but it's so much more than that. It really is a language model with the world's knowledge at its fingertips. And so I think in those two ways, language models, the modern AI, like the third coming of AI or whatever we might call it, is really poised to transform our world in biomedicine.
I love it. I love those examples. We had our first guest was Deborah Pett, the chairperson of the AI task force for ASCO, and she had mentioned ambient scribing as well. And I know it's being investigated in several places. Definitely introduces more time. And then also in these other capacities of just the specialty care, and even maybe the models, even if it's not synchronous access, even a predictive model that tells you or clues you in, kind of a soft nudge, so to speak, of what to order, what to consider, what to prompt. I mean, there's just so much error, in practice because of an overextended system. I mean, the number of times I see a worsening renal function and they're on hydrochlorothiazide, diuretic, plus minus like Lasix, plus minus, metformin and lisinopril and all this. Like it's just cluing in would help. It's not out of ignorance.
Yeah.
Oftentimes it's out of triaging the most scary things, which are abundant first, and hopefully getting to the rest. It doesn't immediately, lead to demise. So with all that said, I would like to talk, if we can, about a couple of, because we haven't really gotten into the weeds of it yet on someone I've recorded with, on some of the problems or concerns that could be involved. So number one, I think about, I'm going to save this one for later, but really data sharing, like the actual diversification of data. And when we say diversification, I don't just mean the geographical location, because in Denver, they're probably more fit and that could confound things compared to, I love Louisiana. It's where I live and bred, but it's just different. But then even things that have to do with the ordering behavior, like at Stanford, presumably everything when it comes to preventative care and primary care and all this stuff and the touches is just very optimized to where even if you are making conclusions based on 5 to 10 years of optimal stuff, and then you mix that into where maybe something is less optimal, where primary care frequently to any frequency is just hard because it's just, it's a rural area where you at best get to see once a year. That's my number one, my concern, because it's easy to say, well, train all these models and get all this machine learning and predictability on as diverse as you can. But then that could dilute for the specific circumstances that you need for the population and with that ordering behavior at a specific location. So I don't know where that falls. Like you could see both arguments in that capacity. And then the second one is really is the sharing and applicability, because what I worry is, say it makes more sense to have training and insights on how the demographic is and the people and the ordering stuff, but then that AI insight gets better. So are we just going to carbon copy it to the places that definitely don't have the economic means, that don't have an academic medical center to study that population, say in southern Louisiana? We have great centers actually, but the population is what I'm talking about as far as being French and just kind of having a different, consortium of polymorphisms, et cetera. How do you see all that happening? Is it kind of the more abled, resourceful, durability of a place will just kind of advance on the things that it's able to bring in because of machine learning and predictability, where the other ones kind of don't? Or do they all share it so that it's applicable both ways and then refine it over time? How does that play out, and what are your concerns?
Yeah, such an important question. The data that we use to train these models is absolutely critical to the output that we're going to get from the models, and it's something we've focused on for many years. If the data and training has certain bias in it, which we know it does, everything on the internet has bias. If it's also biased by only representing a subset of the global population, then it will have that bias. And then if you port it to a different place where those things are different, it may just not perform as well. And certainly we've seen plenty of examples of that. I think a standard, thankfully now many years old, has evolved in the field for publishing medical AI papers, where you have to, at a minimum, have shown it in one other center, preferably multiple other centers, and preferably a center that is very different from the one where you develop the model. And that's certainly the approach that we've taken over the last 5 years and more here. And it basically, if the model doesn't perform in the other center, then you're not going to be doing anything with that model. It doesn't mean it couldn't be useful in the one center where you've trained it, but that is limited. I think we're looking for models that have broad applicability. And when you get to the scale of the models now, when we think about GPT 4.5 or the new Claude Sonnet, or the latest, even the DeepSeek latest very large open source language model, you really are getting to the limits of sort of the world's information and starting to have to think about innovating in other ways. But then to your very point, how do we know the models will operate effectively in a different population other than the ones in which they were trained? Well, in this case, we've tried to train them on literally everything. So it's a slightly different question, which is how do you get the model to the place it needs to be. If you can sometimes think of these models as we call it latent space, which is sort of the embeddings of the information that's deeply held within the model. And it starts in a particular place, and you can prompt it to kind of move into a different area of its latent space. And so you'll get listeners again might have heard of prompt engineering, or the idea of being really smart and savvy about exactly what you type in. Because if you type in a few different words and let's say a much richer prompt, you're going to move the model to a different area of its kind of embedded space, and it's going to give you better answers in general. It's certainly going to give you less generic answers. And so when we apply that to the medical field, I think it's actually very informative, and we have to think very carefully about the data we prompt it with so we can take it to the right part of the model. And this is why it can be so good at specialty about, really rare diseases. And there's great, lots of studies of this now, of course, but when you start to compare humans and language models, and also compare that with humans plus language models, you can do that with rare diseases, you can do it with common diseases, with generalists and subspecialists. There's a pattern emerging, which is that in general, anyone augmented by the language model is in general better than a human not augmented by the language model, which is good. But there's plenty of situations now, several papers in fact, where a language model alone is judged to be doing better than the human plus the language model. And this is better in two ways. One, in terms of making the diagnosis, but two, also in terms of empathy, which is remarkable. When we think of empathy as an intrinsically human thing, we're going to say, surely humans are always going to be better at that than language models or computers or algorithms. We have a lived life, which we know that these algorithms do not. But that is the finding, and often this empathy is judged by other doctors. So it's not even just patients who are saying that's a more empathetic answer. Other doctors are saying this is the most empathetic answer of these two, and then when it's revealed, it turns out the language model was the one that created the more empathetic answer. So does that mean that we're doomed and that we should just step out the room and just hand it all over to the robots? Definitely not. Definitely not, for lots of reasons. And there's some other risks we could talk about even beyond the one you mentioned. But I think the clue to those findings, which are real, those are real scientific studies, the clue and the answer is that we need to teach humans how better to use the language model. So that takes us back to the prompt engineering part, and understand what the model is good at. The model essentially has infinite time, and that's why it's being judged more empathetic in the most part. Sure, there are not very empathetic humans. That is true. But I think most doctors strive towards empathy and really do have a lived life experience to bring to that situation, that doctor-patient interaction. What they don't generally have is time. And if you compare written answers, that's when one of the studies did that, then it's not surprising that this language model has essentially sort of infinite time to write a big long screed and reflect with the patient and just do the things that we've taught it to do in terms of being empathetic. The doctor is rushing on to the next patient and stressfully trying to, juggle two kids and their job and their wife's job and getting dinner on the table and all of the other things. So I think part of this is like understanding how the models can help us so that we can keep the essence of humanity at the center of the human patient, doctor interaction.
Yeah, it's tricky because, empathy, I would argue, is a big reason for people pursuing medicine, but it's not ever interrogated, as a primary point of entry to medical school currently.
Yeah.
And what it is retrieval and recall and ability to really memorize and recall. And to your point, when I'm, now I can use this, is if the literature shows that an AI augmented physician is superior to a physician alone, there'll be this day to where not augmenting is, a little bit reckless or half-assed, right? Where you're like, wait, you don't use AI at all, like 10 years from now, right? So when you have that concept, now there's this whole discussion of what should be the role of, or the assessment of a person applying to medical school. Like, is it their configurability? Is it their adaptiveness? Is it their able to prompt engineer, which takes some, degree of linguistic, prominence and appreciation. I was a philosophy undergrad and everyone's like, why are you wasting your time? And I was like now I can kind of laugh about it because, and say, aha, because it's very relevant. So there's all that. And then the second piece is the empathy. I got to give a shout out. I've never talked about a movie before, but everyone's, talking about this subservience, now this sounds like a normal podcast, which I pride myself that it's not, but Subservience Megan Fox movie with an AI robot, which did a decent job. But the one that really blew me away was Ex Machina. And it's much older. It's actually in 2014. And it actually got into an internal debate in our household about like, well, but it was taught to have emotion. I'm like, look, you can't be taught to have emotion like today. But what you can do is be very effective at knowing what emotion elicits. And it did a great job of being able to, the premise is that basically all the cameras on phones and computers, the company that powered the actual video transmission was using AI and machine learning to see what reactions got what. A bad, show, a bad news article, something that was exciting, something that was frivolous, and learned every single microfacial reaction and the words and the context and everything else. And to where it just got to learn really well. And I'm not going to spoil it, but I think that's a good example, not one to turn away. I mean, if anything, I think anything that's good and productive for someone's emotional health, psychological health, I know you feel the same way, which all has data on outcome anyway, like at least in cancer and I'm sure cardiovascularly, like, just learn and be humble about a lot of things.
Yeah. First of all, I love that movie. And I thought it was really good. I do feel sometimes we're living in a sci-fi world all of a sudden, right? I think for years we would grow up like watching these movies where you talk to computers and they talk back to you in a very lifelike way, even thinking about humanoid robots. Suddenly we're in that world. People are making robots that move like humans. That look
avatars.
Like humans.
There are people falling in love with these avatars that are talking to them on their Vision Pros and stuff because they're just so good.
Yeah. We're suddenly in that world, and I think they have to be wary of the fact that we're moving so fast that we really do need to pause and think about its implication. I think your comment about entry to medical school is a really good one. I mean, we still have the criteria and the approach to medical school admissions that we had like 100 years ago, or where I come from, 300 years ago or 500 years ago. It really hasn't changed. It's focused on how well can you do chemistry? How well did you do in your physics exam? And this is nothing to do. And it's never been predictive of anything. And yet those are the criteria that we use for admission. And we do this. And that's also, remember, it's not even just medical school for people who are going to sit and spend time talking with people and thinking through diagnostics. It's also surgeons who are going to spend, a very significant portion of their time working with their hands. And yet we don't look at hand-eye coordination and your ability to tie knots, or if we said that fighter pilots were going to have to go study chemistry or something similar, or even some basic fundamental element of physics for engineering, and then we were going to decide who the main fighter pilot was, you'd say, well, that's insane. Or if you were going to choose the best NBA basketball player based on some test, you'd say some academic test, you'd say that's just wrong. But we still do that. We still torture our high schoolers with chemistry rather than, thinking about who has the skill and talent to operate in the world they're going to be in, which is this one where these language models will be available to everyone, patients and doctors. And the doctor who doesn't know how to use the language model and the AI and doesn't use it to be a better doctor is going to be a less good doctor as a result.
Right.
And so I think it's a really interesting and important point that
and they're getting out in 7 years, like at the earliest, right? 4 + 3 is the earliest. And so it's like, what world are they going to be in? Like, if one argues that physics is important because it teaches you kind of problem solving, I love it. Fine. I can roll with that. But we know AI can do problem solving. Take all the multimodal considerations when it comes to, especially like at least with cancer, the digital pathology, the radiology, the polymorphisms and all this stuff. And then compare it to real world data or evidence that you can't even possibly query for every, cancer type and demographic and nuance. I mean, it's almost like, what are we doing? But that's a whole different, podcast in and of itself that I'm really interested in doing. The other part though, about the models, this is where I struggle a little bit about, applicability. So, that course taught me a lot because it told me how at AUC of one, we'd say, oh, that's great. And it's like, actually, here there's some areas where it's not. And there's something called overfitness, where something works so well that it's just now too rigid. You want a shoe that gives. You don't want something perfectly 10.5 or 10 because there's nothing in between. So that's why we have giveness, right? That I had to explain that to my child the other day. But then when you talk about the fact that when it comes to, for example, and I love using this example, I don't think I have on a podcast, but when it comes to African Americans in America or Black Americans, so ones that are defined as having certain, basically, the definition of I'm saying that's contrasted from the country of origin that they're familiar with because of the polymorphism. There's features due to what I think is an ugly history of bottleneck effects, etc., where there are certain recommendations that vary from other populations. So my point in sharing all this, bear with me, is that's where it makes sense to have something that done differently, to where, I don't know if it's still this way, but the hydralazine isosorbide nitrate combination was always what I was taught, when I was moonlighting. That's what it is for heart failure in Black Americans versus lisinopril and and long acting. So it's literally different. Same with blood pressure, hydrochlorothiazide versus some of these other agents. That's what swings me back to saying, should we abandon models that aren't everywhere, just in the same way that it's not applicable in every scenario? Or should we dissect them further? I don't know, because we know that there are these things that exist that just vary, like whether it's demographic, whether it's polymorphism, whether it's bottlenecks. I don't know. That's where it gets complicated. And what I have a fear of is that the press is going to have this big AI model fails, it performs so well, but whatever. But we almost need to redefine failure. Like the purpose of what we're propping these things up for now also become very tailored and personalized and precise, which is exactly what we want to a degree when it comes to management and healthcare. That's what we're seeking. So I just feel like it's not gonna derail it, but it'll stall it, because we need to redefine perhaps what we even consider valid. And I don't know who's doing that, or who's even considering these things, what regulatory body or guy. I mean, I don't know. I have no clue.
Yeah. I think it's a really good point that we have to be wary that we don't hold a new tool up to a much higher standard than our current standard. And that's something, we see sometimes comes up quite a lot with self-driving cars. For most of that technology, it performs significantly better than humans. But one error. One incident is enough to make people run because it's new. And I'm not saying that the current standard is necessarily the standard forever, but if a new technology improves on the standard that we are now, then that's the delta.
It's still an improvement.
Yes, exactly. And so I think it's important not to hold the standard so high that we never get the benefit of the new technology, but caution in all things makes sense. You reminded me in the question really about personalization of therapy there. We've talked a lot about technology here and AI in particular, but I've actually spent most of the last decade of my life focused on genomics as a potential route towards something we call precision medicine. It's a version of personalizing medicine, because I do think people understand that if they go to their hairdresser, they're going to ask them what they're looking for, and they'll get a personalized haircut. It's a bit ironic that when you go to your doctor, you don't really often get a personalized care. If you've got high blood pressure, you're going to get the same drug as everyone else. And if that doesn't work, you'll get the next one. And if that doesn't work, you'll get the next one. We really need to move to a world where we understand both disease and individual patients at a deeper level, and we adjust our care, adjust our diagnostics. I mean, the fact we do screening for cancer at the same age, regardless of what your family history of cancer is insane. It doesn't make any sense at all. And so we have to start thinking of personalizing both our diagnostic approach and our therapeutic approach. And fortunately, after many years, genomics is really helpful in rare disease, being able to understand a disease at a molecular level. And it's really broken through there and is now standard of care. But we haven't really seen it had the effect it can have potential in personalizing prescribing through something called pharmacogenomics. I think that's still coming and is available and can save money and save adverse effects from drugs. But also thinking about which diseases are you actually at risk for and getting you focused on those from a prevention standpoint, which takes us really back to the theme we started with around prevention.
Yeah, exactly. And just a responsible, in cancer, a lot of people are like, I can't get the MRI, I can't get the PET, or if I would have, they would have caught it. That's really tragic because they were right. And then the explanation, especially the ovarian cancer, really hurts me. The 30-year-old that has stage 4, and mom says we went 5 times. And it's like, we need smarter allocation of resources, right? I'm not saying we need a Doge. Maybe we do. All right. But your face, just
everybody needs more efficiency.
Right. But there's an allocation aspect. And I mean, there's AI even for that, Lastly, while I have you just for one additional minute, I heard a crazy statistic from somebody that now I'm wondering, like, why am I even asking? But they said something up to 23 to 27% of heart failure, I believe, could be ascribed to, they said family history, like a genetic or genomic. Then I thought about it and I was like, okay, there's collagen issues, there's vascular issues. So there are a lot of pathogenic elements that could contribute to something like that. But it's not that high, right? Like they're mostly behavioral. Or is it?
No. Genetic heart disease is a really large proportion. And if I think the statistic I normally think of is if you take people who have otherwise unexplained dilated cardiomyopathy, so they show up and they have heart failure, their heart's failing, it's big and it's baggy and not pumping appropriately. Now, in some cases, we'll see, it's because you had a heart attack or because your valve failed. Those things are common. If you take the large group of people where there's no obvious answer, and go and look at their family members, like their immediate family members, you find almost half the time, but 30 to 50% of the time, you'll find one of those family members doesn't have a normal heart function either, strongly suggesting that the genetic component is very prominent and that they may have a genetic cardiomyopathy. So, yeah, we always think about family screening if there isn't an obvious other cause. If it's not like, oh, you had a heart attack, or oh, you had this valve problem that caused your heart to be weak. Genetics genetics has a contribution to basically every disease we have. The question is how much of a contribution. For some diseases, it's relatively small. For some, it's almost the whole ballgame. And so I think moving to a world where we have the tools to understand the genome better, where we actually start to use that data in a much more rational way, and integrate it with all the other things we know, because none of it should stand on its own. If we move to that world, I think we really will be in a position to prevent more disease and be more proactive about keeping people healthy for longer.
The concept of epigenetics, I mean, this is where, like, before, which I read somewhere that epigenetics is somehow now being said, like, oh, maybe it's not real. I'm like, how not? Because people have mutations and get cancer and don't.
There's no doubt that epigenetics is real. It's just a word at the end of the day, but
the devaluation, right, of like what you're born with and what actually happens. I mean, the same way as stem cell or anything else. I'd love to know if regenerative medicine is a thing with stem cells and hearts, but I can't keep you all day, so.
Yeah, well, you're right. There's a whole other discussion to have there, but there's so much to talk about.
Well, thank you so much for your time and your insights. And I think, if there's a few call to actions here, it's number one, recognize that sometimes sharing your data is just to get yourself represented better, like, and be more applicable to you if and when you need it, rather than wish that you really knew what your precise, recommendation, be it cancer or whatever else is. The only way is to pull it all together. Use caution and just have an open mind. I think when it comes to what, is failure or not failure, valid or not valid, I think being binary or too reflexive or dismissive can be equally as detrimental, if not worse, to stalling a potential, better health world for all of us.
Great summary. Thanks for having me. Really great conversation.